Welcome back, everyone. We're ready to begin the next session. This will be with Dr. Dooling in the phased allocation of COVID-19 vaccines presentation. Dr. Dooling, please.
Thank you, Dr. Romero. Today, we will revisit the phased allocation of COVID-19 vaccines. Next slide. Once there's a vaccine approved for use, there'll likely be a period when there is insufficient vaccine to meet demand. The objective for this session is to select groups for COVID-19 vaccine allocation in phase 1A, 1B, and 1C. Next slide. In the previous two presentations, Dr. Oliver led us through the domains of the evidence to recommendation framework. Those determinations will lead to a decision on recommendations for any given vaccine. In order to answer the policy question, which groups should be recommended to receive COVID-19 vaccine X during phase 1, we will modify our approach a little and focus on the science, implementation issues, and ethical considerations that inform this important question. Next. As for the science pillar, the work group examined COVID-19 COVID-19 disease burden, as well as the balance of benefits and harms in each group. Of course, details of the phase 3 data will further inform this area when they become available. Next. For implementation, the work group took into consideration the values of the target group and the feasibility of implementation in each of the groups. Next. And finally, the ethical principles. These were presented to ACIP and supported by members at the last ACIP meeting. The principles aim to maximize benefits and minimize harms, promote justice, mitigate health inequities, and promote transparency throughout the vaccine policy process. Next. These three pillars will be used to evaluate the proposed groups for phase 1 vaccination. These groups are healthcare personnel, other essential workers outside of healthcare, adults with high-risk medical conditions, and adults who are 65 years and older. Recall that during the August ACIP emergency meeting, ACIP members expressed support for vaccinating healthcare personnel in phase 1A. Next. Now let's take a moment to review who these groups include. Healthcare personnel are defined as essential workers, paid and unpaid, serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials. There are approximately 21 million healthcare personnel working in settings such as hospitals, long-term care facilities, outpatient settings, home healthcare, etc. Essential workers, those that work outside of healthcare, continue critical infrastructure and maintain services and functions Americans depend on daily. CISA, within the Department of Homeland Security, is tasked with creating the list of critical and essential workers that includes the listed sectors here, including healthcare. The guidance acknowledges that workers who cannot perform duties remotely and must work in close proximities to others should be prioritized for mitigation measures. It also is important to recognize that subcategories of essential workers may be prioritized differently in different jurisdictions depending on local needs. The estimated population for this group is 87 million, but it should be noted that this is a very rough estimate and may be revised as workplaces evolve and find innovative ways to protect their workers and allow work at a distance. Next are adults with medical conditions at higher risk for severe COVID-19. The estimated population for this group is over 100 million adults, and the conditions that put people at risk are being constantly refined according to the evidence and updated on the CDC website. Finally, adults who are 65 years of age and older, numbering approximately 53 million. We can think of this group as older adults living in the community and those who are living in congregate settings. About 3 million adults in the U.S. live in congregate settings such as skilled nursing facilities, assisted living, residential, and HUD housing. The COVID-19 pandemic has taken a tremendous toll on this group, and we will examine this in greater detail later on in the presentation. Next. The next slide summarizes the work group considerations supporting vaccinating healthcare personnel in phase 1A. With respect to science, As of November 21st, there have been more than 220,000 confirmed COVID-19 cases among healthcare personnel, with 822 deaths. COVID-19 exposure that occurs both inside and outside healthcare settings results in absenteeism, either due to quarantine, infection, or illness. Vaccination has the potential to reduce healthcare personnel absenteeism. Long-term care facility modeling demonstrated more cases and death can be averted at the facility by vaccinating staff compared to vaccinating residents. Implementation considerations support the selection of healthcare personnel, as acute care health personnel routinely have high uptake of influenza vaccine, which may predict high vaccine acceptance of a COVID vaccine. Many acute care facilities have the equipment and expertise to carry out large-scale vaccination with a vaccine that requires ultra-cold storage. From an ethical perspective, vaccinating healthcare personnel with a safe and effective COVID vaccine maximizes benefits by preserving healthcare services essential to the COVID-19 response and the overall healthcare system. Also, healthcare personnel group supports equity as it is inclusive of all job types in the healthcare setting, and the group is racially and ethnically diverse. Next. Given ACIP's prior support of early allocation of vaccine to healthcare personnel, I'll now spend the remainder of the presentation focusing on the remaining groups in Phase 1. We'll examine these groups through the lens of science, implementation, and ethics, and highlight the relevant differences. Next slide. First, let's look at the science. Next. These are national estimates of COVID-19 incidence of confirmed cases by age group. As you likely already know, COVID-19 incidence is highest in young adults. Next. On the other hand, COVID mortality rates are highest in older adults. You can see that the national estimates of death per 100,000 population rises steeply after age 55. Next. This figure shows the proportion of COVID-associated hospitalized patients who were admitted from a long-term care facility. More than 30% of hospitalized patients aged 65 to 74 were admitted from a long-term care facility, and more than half of hospitalized COVID-19 patients 75 years of age and older were admitted from a long-term care facility. Next. This table, published from a published paper featuring COVID-net data, shows that compared to people without underlying medical conditions, adults with one or more conditions were significantly more likely to be hospitalized with COVID-19. That risk increased if a person had multiple conditions. Older adults living in the community were also more likely to be hospitalized for COVID compared to younger adults. However, in this adjusted analysis, the magnitude of association for older age was smaller compared to having multiple comorbidities. It should be noted that persons living in long-term care were excluded from this analysis. Next. In contrast to the previous slide, among persons already hospitalized for COVID-19, risk of in-hospital death increased dramatically with age, and adjusted rate ratios ranging from 6 to 11 in age groups that were 65 years of age and older. Next slide. These data together demonstrate that older adults in congregate settings are disproportionately affected by COVID-19. Long-term care facility residents and staff accounted for 6% of cases and 39% of deaths in the U.S., despite the fact that long-term care facility residents account for less than 1% of the U.S. population. The skilled nursing facility population is approximately 1.3 million, and as of November 8th, had experienced almost 500,000 confirmed and probable cases and more than 67,000 deaths. Assisted living facilities are home to approximately 800,000 residents nationally, and although surveillance is less systematic for this setting, states have reported thousands of cases and deaths among these residents. Next slide. Next, I'd like to review modeling data that was presented to the ACIP in October. The question was, what is the potential impact of preventing COVID-19 infections and deaths of initially allocating vaccine to one of the following groups after vaccinating healthcare personnel in Phase 1A? The analysis was updated with a vaccine effectiveness input of 90% in younger and older adults, and to reflect our current epidemiology. Full methods can be reviewed at the ACIP website with the link provided. Next slide. The bars here represent the population-wide averted infections after 6 months from the beginning of the start of a vaccine program, using an infection-blocking vaccine. In other words, assuming that there's no asymptomatic infection or transmission among vaccinated persons. Initially vaccinating high-risk adults or essential workers in Phase 1B averts approximately 1 to 3% more infections compared to targeting persons 65 and older. Next slide. Under the same timeline and assumptions of vaccine performance, but instead considering averted deaths, initially vaccinating adults 65 and older in Phase 1B averts approximately 0.5 to 2% more deaths compared to targeting high-risk adults or essential workers. Next slide. Now, if we consider the extreme scenario whereby the vaccine does not prevent asymptomatic infections or transmissions at all and only prevents disease, the overall percent of population-wide averted deaths are much lower. Initially vaccinating adults 65 and older in Phase 1B averts approximately 2 to 6.5% more deaths compared to targeting high-risk adults or essential workers. Next slide. In summary, the work group concluded that the differences between the three strategies is minimal. Ethical principles and implementation considerations may greatly contribute to the selection of the optimal sequence in Phase 1B and beyond. The largest impact in averted deaths and infections is the timing of vaccine introduction in relation to increases in COVID-19 cases. This really emphasizes the need to continue non-pharmaceutical interventions such as wearing masks and social distancing. This analysis will continue to be updated as we have better information. The factors that will inform interpretation of modeling as we go forward will include estimates of vaccine effectiveness in older adults and the vaccine's ability to prevent asymptomatic infection and transmission. Next slide. So in summary, the work group felt that the COVID burden is high throughout the population and that the differences between sequencing strategies in terms of infections and deaths prevented was small. Next slide. Now let's look at the next pillar, implementation. Next. These results depict survey responses of intent to receive a COVID-19 vaccine as of September. Note that this was prior to any information publicly available about vaccine efficacy. Overall, 62% of survey respondents indicated that they were either absolutely certain, very likely, or somewhat likely to get a COVID-19 vaccine when it became available. The proportion was slightly higher for adults with high-risk medical conditions compared to those without those medical conditions, and higher in adults 65 years and older compared to younger adults. Next slide. In a Harris poll conducted in August, survey respondents reported the early allocation of COVID-19 vaccine to the groups we have proposed for Phase 1, with the strongest support for healthcare workers and seniors. Next slide. These are some of the feasibility issues the work group took into consideration. For essential workers, it will be challenging to reach workers in rural locations, shift workers, those with multiple jobs, or those working in small cohorts. Jurisdictional approaches to overcome those challenges include on-site occupational clinics, pharmacy delivery, health department point of dispensing strike teams. Most jurisdictions have an allocation microplan, which includes prioritization among non-healthcare essential workers, and they're prepared for the period during which vaccine supply is limited. For adults with high-risk medical conditions, One of the biggest challenges may be determining eligibility. Healthcare homes, such as provider offices or pharmacies, could be better suited to verify the underlying medical conditions. Unfortunately, minimum size of vaccine orders and storage and handling requirements may preclude involvement of small clinics. For many, including adults 65 years and older, long distances to travel to central clinics and the necessity of large, high-throughput clinics may be challenging. It should be noted that a federal pharmacy program has already been established to reach long-term care facility residents. Next slide. Values. So ultimately, values considered as a combination of intent to get the vaccine and the values of the population increased from essential workers to adults with high-risk medical conditions to older adults. Feasibility was thought to be slightly higher for essential workers and older adults than those with high-risk conditions. Next slide. Overall, the work group felt implementation would be easiest for among older adults. Next slide. Now on to ethics. Next. This is an application of the ethical principles to the three groups we're discussing. The ACIP was introduced to this application at the October meeting, and additional details can be found in the MMWR publication, which was published today, as Dr. Romero indicated, and referenced at the bottom of this slide. I'll highlight some of the text on this slide, but please note that the darker green color indicates stronger support for that ethical principle. For essential workers, the work group noted that early vaccination of this group would strongly support maximizing benefits and minimizing harms, promote justice, and mitigate health inequities. Vaccinating adults with high-risk medical conditions moderately supported maximizing benefits and promoting justice. There were concerns that diagnosis of medical conditions may favor those who already have access to health care. The work group felt early vaccination of adults 65 and older was strongly supported by maximizing benefits and minimizing harms. There were concerns that the racial and ethnic groups that have been disproportionately affected by COVID so far are underrepresented in this group. Next slide. This slide reflects in the plus system, the summary of the table that we just discussed. Next slide. And this slide reflects the overall assessment of the three groups, considering science, implementation, and ethics. Next slide. As the work group took all of this into consideration, here you see the proposed interim phase 1 sequence, which represents the majority of work group opinion. As previously indicated, Phase 1A would include healthcare personnel. The work group also felt that given the burden of disease, likely benefits, implementation, and ethics, supported the inclusion of long-term care facility residents in Phase 1A as well. The proposed Phase 1B includes essential workers, such as those who work in the education and childcare sector, food and agricultural, utilities, police, firefighter, corrections officers, and those who work in transportation. The proposed Phase 1C includes adults with high-risk medical conditions and adults 65 years and older. Next. This is an example of a schema depicting how the Phase 1 sequence might roll out over time. Two important things to note here are that first, that the phases will likely overlap in time, and it will not be necessary to vaccinate 100% of one group before moving on to the next. Second, that as more vaccine supply is expected in later months, this will allow broader and faster coverage. Next slide. Here are some additional important workgroup considerations. The schema presented here presents an interim Phase 1 sequence allocation policy. Will need to be dynamic and adapted as new information such as vaccine performance and supply and demand become clear. To that end, we will need gating criteria to move expeditiously from one phase to the next as demand saturates. The work group reinforced that reaching essential workers may be challenging and will require jurisdictions to identify critical sectors at risk and optimal strategies to reach them. And it's important to keep in mind that following vaccination, measures to stop the possible spread of SARS-CoV-2, such as masks and social distancing, will still be needed. And ultimately, this interim allocation is a short-term measure. The U.S. government has stated its commitment to making COVID-19 vaccines available to all residents who want them as soon as possible. So that concludes this presentation, and after following ACIP discussion and at the prerogative of the chairs, I'd like to come back and ask the ACIP members for specific feedback on phase 1A, 1B, and 1C.
Thank you very much, Dr. Newling, for that excellent presentation. So we can open this up now to questions and comments from the voting members, and then on to the liaison. So let me begin by asking a question that is somewhat pessimistic. So you've talked about gating for moving from one phase to another as you become saturated. What gating, or will gating be also applicable if there is reluctance by a given group to accept the vaccine? And at that point, will we be offering guidelines for moving on to the next phase if we have significant reluctance in acceptance of vaccine in a group? Over.
Thank you, Dr. Romero. I'd like to say at this point that one of the early principles that the work group came up with was the efficient delivery of vaccine to the population amidst a pandemic. And that remains an extremely important factor as we move forward. So I think absolutely gating criteria will need to take into account saturation of demand for any given phase, and to be able to move swiftly and efficiently on to the next to make sure that we are administering as much vaccine as the system will allow.
Thank you very much. Any other comments tailing on to that? Hearing none. Dr. Atmar, please.
Thank you, Dr. Romero, and thank you for a great presentation. I want to voice my concern about moving persons in the long-term care facilities up to phase 1A. And I guess I have three main reasons for that. The first being that this population is not a population that's been studied in the vaccine trials. I recognize that they have suffered some of the greatest burden, but coming back to the science of it, we really are not able to assess the balance of benefits and harms. And so that'll take me into the next two issues, which is that we have no efficacy data in this population because it hasn't been studied. We know from flu vaccine studies that this population tends to have less efficacy of flu vaccine compared to other persons. I'm gratified by the high reported efficacy in the preliminary analyses from the two companies that we're likely to consider first, but we still really don't know what the efficacy will be in this population. And that whether they're, based on the modeling studies, whether there might be differential vaccine efficacy. And I think that that's still likely. And then it brings me finally to safety concerns. Both of the vaccines we're likely to consider first are reactogenic. And in this case, I do mean reactogenic. And that reactogenicity in this population often leads to additional evaluations, trying to figure out whether there's some intervening infection or other problem. And because we haven't studied this population with the vaccine, we don't know how much that can potentially affect the outcomes in this group. And those of us who see these patients in the hospital recognize that there are often medical interventions that are done in the pursuit of a diagnosis of a change in clinical status that in and of themselves can lead to harm. And so for all of these reasons, I would be concerned about promoting this group to 1A on a theoretical basis that maybe they'll get as much benefit as other persons will over.
Thank you for those comments, Dr. Atmar. Does anyone wish to add additional comments
I
in
do.
that line?
I do.
Please do. Please do.
I agree with Dr. Atmar, and this is as a member of the COVID working group, have really struggled with this and actually have struggled with putting into words some of my concerns. And Dr. Atmar has said a lot of them. I think the one that's hardest for me is that there is such a high mortality rate in long-term care facilities. There will be a number of patients who receive immunization for COVID and will pass away. And it may be regardless of the vaccine, and most likely will be regardless of the vaccine. But early on, as we're building confidence in this, we will not be able to show any data to say that it was not due to the vaccine because there's not been a randomized controlled trial. And I think you're going to have a very striking backlash of my grandmother got the vaccine and she passed away. And they're not likely to be related, but that will become remembered and break some of the confidence in the vaccine. I do think having a randomized controlled trial, even if small, to show the safety would say a lot about this vaccine. We can extrapolate that there'll likely be some efficacy since it's so efficacious in younger adults and older adults who are not in long-term care facilities, but I do not think we can extrapolate any safety data, and I think we're going to need clear safety data for the public.
It's Paul Hunter. Can I make a comment?
Yes, of course you can. Whoa.
So I think that Bob Atmar's and Kip Talbot's comments are really great and I think well thought out. And I think I'm coming, as usual, from a more implementation issue, having worked in nursing homes in part of my career. And it's just going to be, and then the logistical issues of you're coming through and vaccinating the staff, and then you've got the vaccine there, and you've got people who could benefit from the vaccine, and if you skip over them, that's going to be a difficult thing, I think, for the staff to think about, because they really care about their patients, and for some of the family members, sort of the other side of the coin of what Kip Talbot was just talking about. But it doesn't, I mean, I think that everything, you know, as a clinician, I agree with everything that Bob and Kip just said. It's just that you've got the logistical efficiencies of bringing in a bunch of vaccine into a venue, and why not vaccinate people that, you know, you've got it all set up and ready to go. It's an efficiency to vaccinate a bunch of people who could benefit from it. Yeah, that's a real implementation issue that I think we need to keep in mind too. So that's all. Thanks.
Thank you for those thoughts, Paul. Anyone else wish to dovetail onto this conversation?
Yeah, this is Grace Lee. Thank you so much. I appreciate all the comments. I think my struggle is that I'm not sure we're going to have much more information by the time we get to phase 1C, for example. So you could make the argument similarly for, you know, adults 65 and older with, you know, high risk medical conditions that mortality may be higher anyway. And so I guess my concern is that while we wait for that data, you know, I'm not sure at this point, given at least what we know today about the potential efficacy and the safety profile of the vaccine, that it would necessarily dissuade me. I do think it's important that we separated out all adults 65 and older from the long-term care facility residents, where their risk for mortality is much higher. And I do think that there is an opportunity for us to reduce that mortality. And I'm also, I think along the lines of Dr. Hunter, I tend to be a very practical person in that it's hard to get back to some of these locations, you know, from an infrastructure standpoint to ensure vaccine delivery of 2 doses first to healthcare personnel, and then to leave, and then to come back in a later phase to vaccinate all the residents. I do think it's a small enough population that I, you know, would be supportive of it.
Thank you for your comments, Dr. Lee. Anyone else who wishes to add to this conversation?
I'd like to respond to Dr. Lee's comment. This is Dr.
Please do.
Elmer. So I think what we have between 1A and 1C is several weeks, a few months worth of additional safety data in a much larger population to address some of the concerns that Dr. Talbot raised. And I mean, the other piece is, well, that's the main thing I guess I want to say. Thanks.
I'll say this is Pablo.
Yes, please go forward, Pablo.
So I actually support Grace Lee's position more. I just think that it's a really high risk population, and you know, I think that that, you know, first of all, we need to ask the companies to see what data they do have, because I'm not certain how, you know, I know that they were vaccinating some over 65 and over 85. So I think we do need to see some of that data before we can finally make a firm decision. But it is such a high risk group that with appropriate informed consent, I would be very hesitant not to give it. Likewise, even within the essential workers and the healthcare professionals, I'll be upfront, I'm 66, and I'd rather give it to somebody much older and sicker than me. And I just think that we have to really think this closely, because I really think that that's a very important group that ultimately needs it, including the healthcare professionals who work in these long-term care facilities, and even consider for at least one of the visitors who come, you know, one of the families who does come every day to visit, or would like to come every day to visit. Even that's another population that should be considered if we're not going to vaccinate that individual who is in the long-term care facility.
Sorry, I didn't unmute myself. Anyone else who wants to add comment to this?
Jose, this is Hank Bernstein.
Please, Hank, go ahead.
I was one question I was wondering around this issue. I happen to agree. I mean, overall, it's a relatively small population of 3 million compared with the larger numbers. But I also wondered if we were to immunize all the staff, how many of them, if it's not mandatory, how many of them would actually take the vaccine or accept the vaccine? And if I'd feel differently if I knew that all of the healthcare personnel providers working in the long-term care facility were immunized. It might be a little bit different, but I'm not convinced that all of them would accept the vaccine. So this high-risk population would benefit, and logistically, as Dr. Hunter said, it would be appropriate if you're there administering it to everyone there, workers and residents alike.
This is
Thanks.
Sharon.
Go ahead, Sharon.
I would like to also make a comment in support of leaving the long-term care facility residents in phase 1A. I think Dr. Talbot's and Dr. Atmar's comments are very well taken. And I don't think there's really, a solid, a great answer to all these questions. We're trying to figure out what is the best way, find a way. One of the arguments made for a wait and see approach for the long-term care facility residents was it may not work as well, but it might work well enough to save some lives. And this also the concern about reactogenicity in the elders. I have to say I share those concerns very much. But you can also you could also think about adults in the 1C group who will also suffer from some of these same reactogenicity issues, and just the fact that they're older would lead to more workup in those individuals also. Despite the fact that they're not in a long-term care facility, they may also present to their doctors with concerns that would lead to further evaluation. Sorry. Thank you.
Let me also add a comment here, if I may, focusing it a little differently than mortality. So I can only comment, all politics is local, as Tip O'Neill used to say. So my comments are from the local point of view of the state of Arkansas. But when we look at what is currently occupying or coming into our hospital ICUs and our beds, they are a substantial number of patients from long-term care facilities. So the impact of this vaccine may not only be a decrease in mortality, but may prevent an overburdening of our healthcare system that we are most likely to encounter in the upcoming weeks. So I just throw that out as a consideration. And then I cut somebody off, forgive me, please, whoever it was that wanted to say something.
Jose, this is Peter Salagi.
Yes, Peter.
I'm struggling with this as well, but I'm definitely leaning toward Dr. Hunter and Dr. Lee's point of view, and I'm definitely not an expert at long-term care facilities, but it seems to me that the efficacy issue with this relatively small population of 3 million is not as important as the safety question. And I definitely understand the issues of reactogenicity, although I think what I had heard earlier is that older adults are less reactive to these vaccines. But even if the vaccine is somewhat effective, even if the healthcare providers, most of them, they won't all be vaccinated, but many of them will. Other individuals are visiting these in the long-term care facility residents and can easily transmit SARS-CoV-2 to them. So I'm definitely leaning toward suggesting to include them. And one final point is, as Bob said, because there's only a few months between phase 1A and phase 1C potentially, I'm not sure we will have enough safety data within a few months, even if trials can be ramped up very quickly. I'm not sure we would have enough safety data to really completely reassure us. So I think we're all dealing with a limited level of evidence, and these are just very difficult decisions. But I'm leaning toward keeping them into the phase 1A.
Thank you. Anyone else wish to make a comment?
Merrill, this is Ken Schrader with AGS. Is that okay to comment now as liaison?
Yes, please go ahead and speak up a little bit because you're a little faint on the sound.
All right, is this better?
Much.
All right. Yeah, I'm representing American Geriatric Society, and certainly we recognize the important points that Dr. Abmar and Dr. Talbot raised, and certainly support research and long-term care as we go along. But AGS does support moving LTCF residents into phase 1A, given the devastating impact Kathleen mentioned. The potential benefits of the vaccine have not been disproven, and the low numbers of long-term care residents has been pointed out, and also the need for the pragmatic delivery of vaccine to staff and residents at the same time. I want to make a second comment, too, that has to do with the entire phase 1 sequence here. And that has to do with the fundamental principle of aging that informs this sequence. And that principle is the rate of aging and the accumulation of chronic conditions varies widely amongst individuals, which results in broad heterogeneity of health states. In other words, we become more unlike each other the older we get. So using an age cut point alone is problematic because it lumps well elders at lower risk for severe COVID together with sicker, vulnerable older adults with multiple chronic conditions who are at much higher risk for severe COVID. So from AGS's standpoint, 65 plus later on in the sequence like 1C is okay. The trick is where you put the sicker, more vulnerable individuals, and of course they'll fall into the adults with high risk medical conditions. And overall, the AGS is okay with this sequence. Over.
Thank you very much for those comments. Anyone else wish to
Dr.
comment
Romero,
along this line?
this is Amanda. I was wondering
Yes.
if I could ask some of the ACIP members, Dr. Talbot and Atmar and others, and everyone has expressed concern about potentially about events that happen in elderly long-term care facility residents being connected potentially to vaccine. And I was wondering if there was a large effort to make sure that family members and long-term care facility residents and the staff understood what may happen and were educated around vaccines and safety and understood that there were no data in this group of frail older adults. Would that alleviate some of the concerns from those of you who are especially concerned about safety?
This is Dr. Atmar. I guess it would, because that would be in part what you would be doing in a clinical trial if there was some organized way to collect the information, which I think there are plans for. Really, then you're coming back to the efficacy question and taking the gamble that this population is going to benefit at some level that's going to be higher than the groups that they're jumping in front of. And I guess I would, come back and say that, the vaccine's been tested in the elderly, and at least in some of the trials, immunogenicity has been as good in the elderly, but these have been ambulatory elderly and not the physiologically aged that Dr. Schmader was talking about. That's not just age-based. So I think it mitigates some of the concerns, but it gets to the feasibility question. Then how well is that going to be able to be accomplished? Over.
Does anyone else wish to answer Dr. Jones' question?
Yeah, I'll answer in response to that. I think if you're talking about consenting for this vaccine, then I think they would get adequate information. I think just putting a sign up would be inadequate.
Does anyone else wish to offer comment?
Thanks.
Amanda, do you have?
No, thank you.
Okay.
This is helpful.
Thank
I think
you.
we're just trying to make sure that if a decision is made to include long-term care facility residents in this group, then we do want to make sure that concerns are addressed and that we have ways to mitigate some of the potential risk in this group.
Jose, it's Nancy. Can I ask a sort of a change in topic but related topic question?
Yes, please do. And so everybody else who has their hands up, we will get to you. I promise. Keep going. Please, Dr. Massanino.
Yeah, so part of what I think we're all going to be struggling with is a desire to make these lovely lumping categories versus the reality that the health departments and hospitals are going to be faced with, which is, you have 100 people and you have less vaccine and you have to prioritize. And I think, and therefore, I know some of this is frankly going to be beyond the parsimoniousness of eventual ACIP discussions. However, it would be really helpful to have a little more discussion around how you would preferentially decide in terms of healthcare workers, with the following caveat. Based on what we hear from Operation Warp Speed, their estimate is that we'll have approximately 40 million doses of vaccine available in December, or enough vaccine to immunize about 20 million people, because it's 2 doses for each immunization. And then on an ongoing basis, month on month, have enough to immunize approximately 25 million people. And so I say that because if you go to the other slide that Kathleen showed with the lovely lumps that are sort of overlapping, it's okay, you can keep it here, but it's not such a parsimonious choice because it's people. And I guess it would really be helpful to hear from ACIP when they were looking at this categorization. Do they really mean every single healthcare worker should get vaccinated before we move on to another category? Or is the intention of the healthcare worker category meant to be more the healthcare workers that are at higher risk because they're seeing higher risk patients? And that links to me with the question of where to put the long-term care facilities, because if you have to do all the healthcare workers first, that changes when you can get to the long-term care facilities. Jose, I hope that question made sense.
It did make sense, and I will offer my opinions first and then let everybody else gather their thoughts. So I think that given the limited amount of vaccine, that it would be preferential to identify those healthcare providers writ large. That includes those individuals that are not in direct patient care, but have much to do with our ability to see patients. So, for example, in the ED, the housekeeping staff that has to turn that room around very quickly in order to get the next person in. That those individuals at those, quote, front lines, end quote, be prioritized within the healthcare group. Now, it would be ideal if we had enough vaccine for every healthcare worker quickly, and we could move quickly on to other groups, but it doesn't look that way. And I think we need to look hard at our prioritization among the healthcare personnel and begin to at least try to identify those individuals at highest risk for acquisition of the disease. And so I'll stop there and open it up to comment from others. Please, who wishes to go next?
Jose, this is Beth.
Please, Beth. Dr. Bell.
Thank you. I think that this is what Nancy is raising is an important point. And I think it goes to what Dr. Dooling was saying about demand and saturation of demand, and that we need to be moving expeditiously in order to make sure that we make the best use of vaccine that's available as we go forward. And, you know, given all of the discussions we've had about hesitancy and the data that we've seen about willingness to be vaccinated, especially early on, I think as we think about all of these groups, yes, there's the issues about prioritization within groups and risk, as Dr. Romero has just been explaining. But there's also, you know, the idea that not everybody, any group, for example, among 20 million healthcare workers, we're not going to have 100% coverage. And so we need to think of this process as a dynamic process where, as the demand is saturated, and the demand could be for a subgroup of healthcare providers, but as the demand is saturated, we're actually ready to move on to the next group. And we don't wait until we've achieved 100% coverage in any group. This, I think, is, as I say, is a very important principle, because at the end of the day, I think we don't want to be in a situation where, you know, we're not using the vaccine that's available to us as efficiently as possible.
Thank you. Anyone else?
This is Dr. Atmar.
Please.
So I think there were a couple of questions or issues raised, and one of those has to do with the availability of the vaccine. I mean, if there are 40 million doses available in December, as some estimates have played, I mean, that's almost enough vaccine for all of the healthcare personnel, and certainly by the time the second dose is needed, that they should be more than adequately covered. But at least in the institutions in which I've had the opportunity to participate in planning, it doesn't sound like those kinds of numbers are going to be available. And so some of the prioritization that we've gone through has been just the same kind that Dr. Romero discussed in terms of which healthcare personnel would be targeted first. I guess it also raises a question about, as vaccines being allocated to different institutions, whether the second dose should be held for the individual who's already received the first dose or used on the next healthcare worker who might step up. And at least in some of our planning, the assumption was that we would get vaccine to do the second dose administration through a subsequent shipment. So that might be something that could be addressed through the FAQs. Over.
Thank you. Anyone else?
Yeah, Jose, this is Pablo. I think that, what Nancy and what you brought up are critical because unfortunately, not all healthcare workers are equal in terms of risk. And I do think that some of us, I know in ID and neonatology, I have ample PPE, and some others may not in an emergency, more of an emergency situation. So I do think that within institutions, we're going to have to prioritize which ones will get it. But I also agree that, we look forward with another supply coming in a month, then we can vaccinate more upfront rather than save the subsequent dosing.
Anyone else?
This is Marcus Plusha with ASTO, Association of State and Territorial Health Officials. I just wanted to mention we've had several conversations about this with the leaders of state public health departments. Actually, the last one on Friday that was queued up by Dr. Messonnier. But I just wanted to sort of raise the issue that I think amongst state public health officials, there is pretty strong support for vaccinating healthcare workers. And although there was some discussion around, maybe some more than others, I do think there's the fact that, healthcare workers, not only are in contact with lots of people, but they're also in contact with people who are very vulnerable. And that maybe makes them a little different from other essential workers. And then they are also a very important part of the response as far as taking care of people and being the ones to vaccinate other people. So those were the themes that were raised in the conversation that we had. And I think that's the one place that there was a pretty strong perspective from our constituency.
Thank you for those comments, Dr. Plusha. Next, anyone else?
Hi, this is Molly Howell with the Association of Immunization Managers. I just wanted to echo a lot of the comments about logistically vaccinating staff and residents at the same time being much easier. I also feel like going to a long-term care to vaccinate staff will lead to higher uptake versus expecting staff to come to a mass vaccination clinic held off-site. I'm wondering if there are any plans to update the modeling data that was presented in August to potentially look at what it would mean with a higher efficacy rate in the elderly population, and if consideration for uptake of staff, especially if we're expecting between 40 and 60% of long-term care staff to accept the vaccine, how much of an impact that will make on whether or not residents should be vaccinated. I also just wanted to mention that the discussion earlier around people who have been recently infected with COVID or prior positives, if that may impact this somewhat. I think a lot of long-term care staff and residents have already had COVID, and I think that could also inform some decision-making and allocation if if you're looking at potentially delaying people who were recently positive for COVID-19.
Thank you very much. Are there any other comments along this line before I return to the queue?
Yeah, this is Hank again, Jose. Did I hear that some were that there was a discussion that people were going to be prioritizing within healthcare personnel who gets vaccine and who doesn't? Or because I thought by definition they were paid and unpaid, serving in healthcare settings, and they're essential for the COVID response and also have high risk of exposure. So I just wanted to make sure I didn't hear that there were going to be prioritization within the healthcare personnel group.
Dr. Bernstein, this is Amanda. I can clarify. What we were talking about is that given the very limited number of doses likely coming available, like in week 1 and week 2 and week 3 of after a vaccine authorization, not all healthcare workers will be able to be offered vaccine at the exact same time. So it's sub-allocating, but from we're talking about a difference at the very local and hospital setting. How do you arrange your staff over the course of a couple of weeks, for example? Does that make sense?
Yeah, just for practical logistical concerns, sure.
Well, actually, this is Grace Lee. If I could extend on that a little bit, or a comment on that comment, which is to say that I do think, well, at least the intent that I'm thinking about is that early allocation is for what I'm going to call quote unquote essential workers who need to be in the workplace. And that those who are able to work remotely as part of their job function, as long as even next summer, perhaps should not be at the front of the line, even if they are considered healthcare personnel. So some of our healthcare workers will qualify technically in 1C, but might not be actually in the workplace interacting with patients or other staff. And so I do think that the allocation piece is not only just for the first few weeks, but it's thinking about it from a public health and community standpoint. If we have healthcare workers who are able to work remotely until next spring or summer, I think we should be vaccinating and moving on to phase 1B and perhaps 1C, and then capturing the rest of our healthcare workforce that way. I don't think we should actually have the gating criteria be set at 100%. I actually think we're going to need that flexibility because we don't know exactly what the supply will look like in the early weeks. And, this is where I think close partnership with our public health colleagues will be critically important to make sure that we are not trying to vaccinate 100% of our healthcare workforce if some proportion of our workforce can work from home.
Before we continue on with more comments on that, there's a piece of information that was just given to me that I want to throw out there for everyone's consideration. So I was just informed that 30% of all long-term care facility residents turn over at 30 days, which means that we would have to be revaccinating in those populations every 30 days or so in order to keep up with that change in new population. So I'll see if anybody else has any other comments they want to offer.
Yeah, this is Pablo. I just wanted to absolutely agree with Grace's comments. I agree with her completely.
This is Jeff Duchin.
Yes, Jeff.
I'd also thank you. I'd like to emphasize from my local public health perspective how important it is to have clear guidance on this sub-prioritization business. Because all first shipments of vaccine will go to large healthcare systems that have the appropriate storage for these ultra cold, and they may want to vaccinate everyone in their facility, tertiary care centers. Yet we know that the risk is highest in the community at the long-term care facility level. That's where most of our healthcare workers are becoming infected. So I think for equity purposes. And for allocation decision-making, we need to have rather, I think, specific guidance that's consistent. And in the same vein, when we talk about long-term care facilities and healthcare workers in the same tier, we would like to know how do we allocate the supply that we're getting between those two sectors. Over.
Thank you. So we have to move on. We have several things else to talk about. Does anybody have a pressing need to make a comment on this before I turn back to the queue? Okay, so let me go to the queue, and then I'm going to ask you to keep your comments fairly succinct. We won't ask for follow-up commentary to the question or comment. We'll just move through the queue as we have in the past. So Dr. Zahn, you're top of the queue, please. Okay, we can come back to you if your hand is still up. Dr. Kimberlin, I see your hand is up.
Yes, it's a clarifying question. I'd like to confirm that the people who work in long-term care facilities are considered healthcare workers and therefore qualify under phase 1A. I'm talking specifically of people who bring the laundry into the facilities, who carry trays of food into patients or residents' rooms and so forth. I'm not talking about the nurses. I think they're considered healthcare workers pretty much outright. How about everyone else working in the facility, regardless of what the decision is about whether long-term care facility residents are considered phase 1A or not?
Thank you.
Dr. Dooling, do you want to?
Yes, please. The response to that is yes. All workers working in a long-term care facility, which would be considered a healthcare facility, are considered healthcare personnel.
And so they will be in phase 1A no matter what the decision is about long-term care facility residents.
That's correct. They are considered healthcare personnel.
Thank you.
Thank you for that question. Dr. Rockwell.
Hi, thank you. I actually have been holding off on my comment because Dr. Nancy Messonnier started off my thread of thought in that I'm hoping for a little more guidance in terms of phase 1A, assuming insufficient vaccine supply to get through phase 1A before it is expected to start phase 1B, in that perhaps healthcare personnel who have high-risk medical conditions and who are older may be prioritized over others given limited supply. Over.
Thank you. Ms. McNally, please.
Thank you. I'm just wondering about acceptability for long-term care facility residents, and I'm looking at slides 25 and 26 and wondering if that population was contemplated. So that's the whole, and let's see, the intent to receive COVID-19 vaccine, September 2020.
Thank you. So this survey reached out to individuals and stratified by age, less than 65 years old and older than 65. And I do not believe there's an attempt to make a separate group consisting of long-term persons who reside in long-term care facilities.
Thank you. Dr. Whitley Williams, please.
Thank you, Dr. Romero. I just wanted to comment on the fact that by vaccinating healthcare workers in long-term care facilities, just to make note that some of those workers also live in communities where COVID is of higher risk. So indeed, getting them vaccinated does help, hopefully will help and protect them from becoming infected and then going home and spreading it more within the community. And it's true also for the hospitals and vaccinating both essential, all healthcare workers, whether they're in housekeeping or dietary or on the healthcare side.
Thank you. Dr. Eckhart, please.
Thank you. On behalf of the American College of Obstetrics and Gynecology, I'd just like to raise the point that since the allocation plans do not mention pregnant women or lactating women, many of whom will be in the Tier 1 allocation groups, how can this special population be addressed? Thank you.
Thank you. Dr. Eckhart. Okay.
That was just me. I'll take my hand down.
That's fine, thank you. Dr. Hayes.
Yes, Carol Hayes with the American College of Nurse Midwives. So I'm curious if the American Hospital Association has been brought into these conversations about the percent of employees of healthcare systems and hospitals that are considered providing direct patient care compared to the employees of health systems and hospitals that are not providing, or, as everyone has mentioned, housekeepers and the dietary delivering the trays. But I feel like there's a tremendous number of people that work in health systems that are not providing care, and it might be easy for them to come up with a policy dovetailing with all of this conversation about how hospitals can go about prioritizing which members of healthcare professionals and employees of essential workers within the hospital need to be vaccinated first.
Thank you. Dr. Freihofer, did I jump you? I'm sorry. Did I skip you just now?
Yes, you
up?
did.
Yes.
But
I'm very sorry. Very sorry.
Okay. Sandra Freihofer, American Medical Association. I really appreciated Dr. Sanchez's comments about access to PPE. And just a reminder that there are many small community practices that are seeing patients that are on the front line that don't have access to protective equipment. A lot of, if you go online to try to order this from some of the companies like McKesson and Henry Schein, they've allocated their N95 masks to the hospital. Small practices can't get them a lot of times, and small practices have had to resort to, having small opportunities to get in a group purchasing sort of thing. So it can be very difficult for small practices to keep their staff protected. And remember that 40 to 50% of patients with COVID are asymptomatic. So even if patients say they're not having symptoms or they don't have a fever, they're still putting our employees at risk. And also wanted to echo the emphasis on making sure our essential workers are covered, because the people that bring in the food, that prepare our food, that do all these things that help our nation work, they can't stay home. They can't telework. And we've got to make sure that they're protected.
Dr. Freihofer, this is Amanda. I think you just segued perfectly into the next question that we want to address. Dr. Romero, do you want to?
Yeah, so let me just make sure really quick. Dr. Zahn, your hand is still up?
Yeah, can you hear me?
Yes.
Okay, sorry for the audio before. So yeah, I mean, it's just from a local public health standpoint, I wanted to again agree with what both Dr. Hunter and you, Dr. Romero, and Dr. Juchin have said on a couple of points. One is that we really need guidance in terms of exactly how this vaccine is supposed to be allocated, even on the 1A level. What we're going to get, I presume, whenever we have a situation like this, you ask for hospitals or healthcare systems how much vaccine you want. They ask for as much as they possibly can, and they say, well, I'm going to ask for the moon. It's up to local public health to give us what they can. We really need guidance and clarity as to what we can tell them they really ought to be asking. That's one comment. Another, just to mention, follow up on what Dr. Hunter had said regarding vaccination of long-term care settings, to start out with staff and then to go back again to residents would be difficult. And I'd also just say, in terms of the conversation with long-term care facilities, if we don't vaccinate the residents, then the impression there is we're using the staff, we're going to vaccinate the staff, we're going to make sure they're protected, but also to protect the residents. I think we all are operating under the impression that at the beginning, all of us can decide whether we think it's appropriate for us to receive the vaccine or not. And it just feels like that conversation with the staff to begin with, to say, we're not going to vaccinate your residents who are at the highest risk, but we want you all to get vaccinated. And a lot of reason we want you to get vaccinated is to protect them. That becomes a very complicated conversation, to my mind, from local public health when you're talking to these providers, when there's going to be understandable hesitancy at the beginning as to who wants to get the vaccine and who doesn't.
Thank you.
Thanks.
Thank you. Dr. Hayes, your hand is still up. I just want to make sure that you have your chance to speak.
I apologize. I'll take my hand down.
No, it is nothing to apologize for. I want to make sure everybody gets a chance. Ms. McNally, you too?
My apologies. I'll take it down.
No apologies necessary. Okay, so we'd like to move on to the next question, which is, could you discuss the same issue of prioritization between essential workers versus high-risk adults older individuals in 1B. And if either Amanda or Dr. Kohler or Dr. Dooley want to add further clarification on that question, or is that good enough?
Yeah, Dr. Romero, I'll let Dr. Dooling speak after, but I do want to just let everybody know that this is an amazing conversation. We need to start our public comment period at 4:40, and we would like to hear from each ACIP member before we do. So we only have about 10 minutes to have this conversation. So we'd really like for people to speak in a focused way to answer this question, and please email us if you have additional input. Dr. Dooling?
For the ACIP members, that was.
Yes.
Thank you. So we'd like to hear from ACIP members now about the following three questions. First, do members agree with healthcare personnel and long-term care facility residents in Phase 1A? Next, do you agree with essential workers, non-healthcare, in Phase 1B? And finally, do you agree with adults, high-risk medical conditions, and adults 65 years and older in Phase 1C? I'll return it to the chairs now.
Okay. We're open for comment.
Yes, specifically on 2. Do ACIP members agree with essential workers in Phase 1B?
Dr. Szilagyi.
Hi, thank you. Just very briefly, I do agree with essential workers in Phase 1B. Having thought about this a lot, I agree that the science and the implementation, there's some pros and cons with each group, but they're relatively similar. And to me, the issue of ethics is very significant, very important for this country, and clearly favors the essential workers group because of the high proportion of minority and low income and low education workers among the essential workers. So I do agree with this. Thank you.
Thank you. Ms. Bata.
I just want to echo what Dr. Szilagyi said. That this is where we can really elevate the issue of health equity. And having been working in our response, where we see an intersection between essential workers and their community, is where we've seen the greatest amount of disease.
Thank you. Dr. Paling.
All right, thank you. First of all, I'm going to agree. The importance of the non-pharmaceutical measures, even during this allocation, is really important to highlight. We also appreciate the focus on maximizing benefits for all. The challenge is how to best allocate vaccinations among all groups who would benefit until it is so widely available. The science, implementation, and ethics conversations have been very important, and to me, the maximize the benefit, promote justice, and mitigate inequities is very important. And so I would agree with the long-term care facility residents in 1A. I agree with essential workers. Over.
Thank you. Thank you. Dr. Bell.
Thank you. I want to also agree with having the essential workers be in Phase 1B. I think that, the initial rollout of this vaccination program will set the tone. And I think if we're serious about valuing equity, that we need to have that baked in early on in the vaccination program. I think that, as others have said, these essential workers are out there putting themselves at risk to allow the rest of us to socially distance and et cetera. And they come from disadvantaged populations. They live in disadvantaged communities. And recognizing that not all of them may want to be vaccinated at this stage, we need to provide them with the opportunity early on in the process. And so for those reasons, I think that this is an important message to be sending. So that we need to do that. Certainly, we will continue to evaluate as things develop, but I think that to begin a vaccination program with a very strong statement about equity, especially given modeling results that don't show that there's a huge difference in terms of science among the three groups, is extremely important. And while I have the floor and to sort of move things along, I'll say that in terms of phase 1A, I really appreciate the concerns that have been raised about including long-term care facility residents in phase 1A. But I do think on balance that it's a reasonable thing to do. I think that while we can imagine that vaccine efficacy will be considerably lower in this population, if we're starting at such high vaccine efficacy, I think it's reasonable to suppose that there will be some efficacy, and given the mortality and the impact on the healthcare system from the number of nursing home residents that have been dying, I think on balance it makes sense to include them in phase 1A.
Thank you. Just a second here while I check my list. Dr. Hunter, forgive me. Go ahead.
Hi. Paul Hunter. I strongly agree with all three phases, 1A, B, C, and especially the principles and the topics that went into forming how that was done. The process is really excellent, especially, putting safety and efficacy first, and then the implementation and the ethics, equity issues. I think the point, one additional thing I wanted to say was that that process may need to be repeated over and over again at state and local and even smaller planning levels. And as much as that process could be put into guidance that would be helpful and clear to folks at those levels, the better as far as I'm concerned. Thank you.
Thank you. We can come back around if people have additional comments about this next part, but we've also been asked to make comments regarding the thoughts of the prioritizing the essential workforce over high risk, over individuals with high risk medical conditions. So if you can comment on that also. Never mind. Never mind.
No, I think that's.
Go ahead, Doctor.
I think this is Paul Hunter. I strongly agree with that, and for equity reasons. Thanks.
All right, thank you very much. I'm getting cross messages here. Too many messages at one time. Dr. Alt, forgive me. Go ahead.
Thank you. Was the list of people that went into 1B decided in the previous pandemic? I think we discussed that several meetings ago, and I don't remember how we came up with that list of people. Basically, I'm thinking it is how have we missed anybody?
Hello, this is Dr. Dooling. The list of essential workers is determined by CISA, which is an agency within the Department of Homeland Security. It is long and it is detailed, and any given jurisdiction may choose to prioritize some over others, and some essential worker classes may not be relevant in every jurisdiction. So it is a list for the country, which may need to be adapted locally.
You did mention that previously, but I didn't know what CISA meant, so thank you.
Dr. Bernstein.
I just wanted to comment and agree with the majority here that with essential workers being in phase 1B, I think equity is a priority to protect vulnerable populations. It was even added as a domain to the evidence to recommendations framework. I think these workers are essential. They're fundamental to our response to COVID, and they're at risk because they work in close proximity to others. And so I totally agree that they belong in that group to be vaccinated.
Thank you. So I will agree with everything that has been said previously. Also agree with the stratification of phase 1B essential workers. Now, for the sake of saving time, I won't make any additional comments. But what I would like is for any of the liaisons to please offer comment at this time.
And Dr. Romero, I think we have a couple of other ACIP members who haven't spoken as well. So if any ACIP members who haven't spoken and want to express an opinion and or liaisons, please raise your hand.
Thank you. Let me go to Dr. Howell, please.
Hi, Molly Howell, Association of Immunization Managers. I was just wondering on slide 13, it looks like the death rate or the mortality rate among those 80 and older is significantly greater than even the 65 to 79. So, and I don't know what percent are in long-term care versus not. So I'm just wondering if there's been any thought to stratifying the 65 and older age group or changing the age for that age group at all.
Thank you for that question. Dr. Szilagyi, your hand is up. Did you wish to make another comment?
No, I didn't. I'm sorry.
Okay, I'm just making sure that nobody's being missed. Dr. Atmar, do you wish to make another comment?
Well, I'm responding to Dr. Cohn's request that
go ahead.
Responded to, and I support essential workers over adults with high-risk medical conditions for the reasons that have been addressed already. In addition, the ability of these workers to mitigate their risks of potential exposure due to going to work is less than persons that are currently in 1C. Over.
Thank you. Dr. Luckman.
Thank you. I also just wanted to reiterate, number one, given the very high mortality rate of the elderly in long-term care facilities, it seems reasonable to provide them with the opportunity to benefit from vaccine. I want to applaud the entire conversation today around the emphasis on equity and identifying that the racial, ethnic, and low-income disparities and the impact of COVID warrants prioritization of essential workers. And I hope that as we think about the adults with high-risk conditions and adults over 65, that we also recognize the racial and ethnic disparities and the risks to those populations as well. And thank you for a robust discussion today.
Thank you for contributing. Dr. Fry.
Thank you. I mean, I think it's important that we all put our thoughts out there on the table so we can take a temperature of the group. I have to say that I agree with what has been said by many of my colleagues. I do believe that phase 1B essential workers should be in group 1B. And I don't have anything else to add other than to say that, these decisions are difficult. There's no perfect solution. And it will be up to the local areas to the final prioritization of how groups move through within groups. Thank you.
Thank you. Are there any other comments from the liaisons or from the voting members? I'm not seeing, Ms. McNally.
Dr. Romero, I would add that I agree with this prioritization from the consumer perspective, echoing all of the sentiments that have been expressed by those in support.
Thank you very much. Anyone else? I don't want to cut anybody off that wishes to make a comment. Okay, I'm not seeing any hands. Dr. Dooling, Drs. Cohn and Ms. Onier, have we addressed the questions? Do you need more information from us?
No, thank you very much. I'd like to thank all the ACIP members, liaisons for giving great feedback. Thank you.
Thank you. And let me say the same. This has been an outstanding and robust discussion. Do we have time for a break, Dr. Cohn?
Dr. Romero, Dr. Messonnier would like to make a comment before we break, and then we can actually break at 4:30. Thank you, everyone, for, I apologize if I made you guys speed talk, but thank you very much. We will start, Dr. Messonnier wants to make a comment, and then we can break until 4:40 for the public comment period.
Thank you, Dr. Cohen.
I just wanted to take a minute to be sure to thank the ACIP members, the ex officio members, and the liaisons for today's meeting, but also in general for their dedication to ACIP, which we've clearly seen in their commitment to this process. There are many things that we're not sure of, but one thing that I am sure of is my trust in ACIP, the process and the members, the diligence and passion of the members for what they do. You have several really huge decisions in front of you. The first being the recommendation for a vaccine, and the second being the really complicated and difficult discussion that we were just having around early prioritization when there is limited quantities of vaccine. I think, as someone just said, there aren't any perfect decisions. And I know this is something that most of you didn't anticipate doing, making these kind of huge decisions in the midst of a pandemic. But I also know that in the past, ACIP has made many good recommendations that we at CDC have relied on for many years. And I trust you and I trust the process to help us make the correct decisions now. So thank you for everything that you're doing and for what you'll continue to do to support CDC, the government, and the public. Thank you.
Thank you for those comments, Dr. Messonnier. They're greatly appreciated. Then I think at this time we'll break and come back as stated by Dr. Cohn in approximately 15 minutes. Thank you.